Okay, perfect. Let's go. All right, so management of care. So last week we stopped on disability. All right, so disability covers management of care and safety and infection control. All right, so fourth disability. Hold on, let me get my notes. Assess for current or evolving disability. So you want to assess after ABC, you want to assess for current or evolving disability. And you want to, that means that you're looking for neurological deficits and a stroke in evolution. So go ahead and underline stroke. All right. So if someone is having, some type of emergency, you're always assessing the patient for strokes. Simply because just of the environment that we live in, is cardiovascular health, is heart attacks, strokes, high blood pressure, cholesterol plagues the community. So for 194 disability, letter A is disability, and implement actions. So think about the type of actions that you would have to implement. Implement actions to slow down development of disability. All right. So B is disability. Implement actions to slow down development of disabilities. All right. So you may have to give that patient a beta blocker, or you may have to give that patient something to get the blood pressure down, or do something to ensure that there's a slow down of development of disability. All right. So 195. Fifth is exposure. So remove the client's clothing to allow for a complete assessment or resuscitation. So A is resuscitation. You want to remove the client's clothing. So it's okay in that instance to remove the clothing. B, implement measures to reduce the risk for hypothermia. Now, if you're taking your exit exam, I want you to pay very close attention to this warming blanket. So if someone is hypothermia, if they're at risk for hypothermia, that means they're cold, right? And IV solutions, or using cooling measures for clients exposed to extreme heat. So look at that. It says warm blanket. You want to give somebody a warm blanket if they're cold, and then a cooling blanket if they're hot. So warm blanket if they're cold, cooling blanket if they're hot. So remember that. All right. Safety risk reduction. Look first for a safety risk. So think about safety first. For example, is there a finding that suggests a risk for airway obstruction, hypoxia, bleeding, infection, or injury? So look first for a safety risk. Next, ask, what's the risk to the client, and how significant is the risk compared to other posed risk? It's significant. C is next. It says give priority. So C is priority to responding to whatever finding poses the greatest risk to the client's physical well-being. So what's an example of giving priority to responding to whatever poses the greatest? Let's say, for instance, if there's a snake, you want you want to get the pay from the snake, right? All right, 197A. Use the nursing process. So A is nursing process to gather pertinent information. So this is also a way that we prioritize our care. Remember ADPI: assessment, diagnose, plan, implementation, and evaluation. So you always want to use a nursing process. You always want to use that order. The first thing we do is assess, and then we diagnose, we plan, we implement, and then we always evaluate. So even in an emergency situation, you always want to think about your nursing process. So this is who we are. We're nurses, so we have to use the nursing process when dealing with any type of patient. And B, for example, determine if additional information is needed prior to calling the provider. All right. So when you're doing your assessment as a nurse, is this doctor working with 2 patients, with 3 patients? Does a patient need something for pain? Does a patient need something for blood pressure? Does a patient have a skin infection? So you want to make sure that you gather all the information before you call the doctor. All right, 198, survival potential. This is also something that we use to prioritize our care. So use this framework. It's a framework for situations in which health resources are extremely limited. So when survival potential is that client who has burns over 70% of his or her body, what's the survival potential of that? Is that going to be your priority patient? So use, when we're in the field, you always want to think about survival, and underline that. Is the patient going to survive this? Because we essentially, like, guys, I know it's kind of cold, but you don't want to use your resources on someone who's not going to make it. There's limited resources, so we have to think about survival potential all the time. All right. And give priority to clients who have a reasonable, so underline reasonable chance of survival. Clients who have a limited likelihood of survival, even with intense intervention, are assigned the lowest priority. Remember, this is how we prioritize our care. All right, guys, give me just 1 second, okay? I have to let someone in. Give me 1 second. All right, let's go. Guys, if you're listening on StreamYard, please check your spam, all right, for your link. I sent it to your spam. All right. So least restrictive, least invasive. This is also something that we use to prioritize our care. This is a big deal, guys, especially when it comes to restraints. So I want you guys to think about write down restraints. Just write restraints because this is what they're referring to. Least restrictive, least invasive. All right. So select interventions that maintain client safety. All right. You want the client to be safe, but you want to pose the least amount of restrictions to the client. So A is maintain. You want to select intervention that maintains client safety. B, for example, if a client who has a high fall risk index is getting out of bed without assistance, move the client closer to the nurse's work area rather than choosing to apply restraints. So B is restraints. You want to do the least restrictive, least invasive first. Select interventions that are the least invasive. So, for example, bladder training for the incontinent client is better than a Foley. So, D is bladder training. That's the least restrictive, least invasive. So, you guys have got to know how to educate your client on bladder training. So, write that down. Okay, bladder training is huge. We also use acute versus chronic. We use urgent versus non-urgent, and we use stable versus unstable. So this is also a way that we prioritize our patient care as nurses. So a client who has an acute problem takes priority over a client who has a chronic problem. So a client who has an acute problem is someone who is having an MI, a myocardial infarction. That's acute. Someone who has a GI bleed, that's acute, over someone who has diabetes mellitus type 1. That's chronic. Believe it or not, COPD is chronic. So you want to think about your acute over chronic. And a good example, if someone is having a stroke or if someone is having an MI. B, a client who has an urgent need takes priority over a client who has stable findings. So a client who has urgent needs. So what's an urgent need? Let's say, for instance, a patient has a stab wound. That's going to be priority. If someone is having a stroke, signs and symptoms of a stroke. If someone is having a seizure. All right, so let's recap really quick. So now we're talking about priority interventions. So first, as nurses, we're always concerned with airway, breathing, circulation. That's first. All right. Disability, that's your patient who's having neurological deficits, right? And then fifth is exposure. This is a client who may be near having a heat stroke or someone who got bit by a snake bites. Safety risk, again, maybe someone is in a puddle of water and they're being electrocuted or snake bite. Assessment, we use the ADPI, assessment, diagnosis, planning, implementation, and evaluation. Survival potential, remember those codes. It's the tags, black tag, red tag, yellow tag, green tag, because you don't want to use resources on patients who are not going to make it. Think about survival. Least restrictive, least invasive, that's restraints, guys. What can I do before I give this patient a physical restraint or a chemical restraint? And then acute versus chronic, urgent versus non-urgent, and then stable versus unstable. So we always want to go to the acute disorder, urgent needs, and we want to take care of the unstable client first. All right. And never delegate an unstable client. All right, guys. Evidence-based practice. All right. I know we don't like to talk about it because it's boring, but this is management of care. So let's just get through it really quick, okay? Actually, let's go to establishing priorities. Let's go to 209 first. Let's just stick with this one. Go to 209, all right? That's better. We'll talk about evidence-based practice a little later. It will be quick. All right, so 209 is prioritize systemic before local. So remember, systemic before local injury. So it's life before limb. So if someone is bleeding out, if someone is going into cardiogenic shock, you want to make sure that you deal with systemic before local. So what are some systemic issues? That's if someone is having a stroke, or if someone is having an MI, or if someone is bleeding. Okay, so always prioritize a systemic before local, life before limb. Prioritizing interventions for a client in shock. All right, 210 is shock over interventions for a client who has a localized limb injury. So, shock. How do you know your patient is in shock? So, vital signs: blood pressure will be low, heart rate will increase, respiratory rate will increase. So, if you always want to prioritize your interventions for someone who is in shock. A person may have a person, oh man. Oh, all right. 207. A person may have oh, that kind of threw me off. What was I saying? Oh, a person may have internal bleeding. Okay. So you're looking at, you may not see blood leaving the patient's body, but you'll see the vital signs. Prioritizing acute. So it's less opportunity for physical adaptation before chronic. So acute before chronic. All right. Prioritizing the care of a client who has a what? New injury, illness, or an acute exacerbation, like if someone is having an asthma attack. Prioritize actual problems before future problems. So this is the reason why your clinical instructor didn't want risk for this. They want you to give them an actual problem. The patient is there for a reason. What's the actual problem? Let's not talk about a risk. What is going on now? Why is the patient in the hospital? And 210, prioritizing administration of medication to a client experiencing acute pain over ambulation, right? Make sure you remember this: acute pain. Pain is the fifth vital sign. So if a patient is at pain and you have a patient who's at risk for thrombophlebitis, you have to take care of the patient who is in pain. So 210 is acute pain. Listen carefully to clients and don't assume. Pain is what the patient says it is. You have to listen to the client. If the client is telling you, listen, I have never seen this medication a day in my life, listen to that client. Asking a client who has a new diagnosis of diabetes mellitus, what they feel is most important to learn about disease management. A new diagnosis of diabetes mellitus. How do you feel about this disease? How do you feel about COPD? How do you feel about whatever the system disorder is? Because then you'll know, okay, they are ready to manage the disease. So always assess the patient. Is the patient ready? Does the patient know what's going on? Recognize and responds to trends versus transient findings. What is a trend? A trend is, okay, I noticed that the blood pressure keeps going down. So it was the systolic was this, the diastolic was this. Now it's 10 millimeters of mercury below what it was 10 minutes ago. Or you can look at the O2. The O2 sat keeps decreasing. So you always want to look at trends. All right. So as opposed to, I'm not going to call a doctor for a transient finding, meaning that I didn't put the O2 monitor on correctly. I didn't put the pulse ox on correctly. And then I'm calling a doctor for an 85 O2 set. If I would have just waited or warmed the client's hand, the patient's at a 99. So you have to know when someone is really declining versus a transient finding. So you don't have to rush. If there's a blood pressure, redo the blood pressure if there's a high blood pressure or a low blood pressure. All right. So you always want to look at trends. Now, I'm not saying that you know for a fact that the patient's blood pressure is 40/60, and you're like, no, I'll come back 5 minutes later. Don't do that. All right. But you definitely want to take blood pressure in both arms or use a manual blood pressure before you call the physician. Recognizing a gradual deterioration in a client's level of consciousness. It's a level of consciousness. Is the level of consciousness decreasing? So you must know how to read your Glasgow Coma Scale. All right, so I put a little worksheet in this here so you can practice, okay? So this is huge, guys. All right, so you have to recognize that the patient is deteriorating, all right? The patient is declining. So recognize the indications of medical emergencies, especially if your client has a new diagnosis. So recognize indications of medical emergencies and complications. 216 is medical emergencies and complications. So your board, remember, your board wants to know, okay, is she going to know, is he going to know if his patient is going into shock? So 216 again, medical emergencies and complication, especially in a client who has a new diagnosis. 217, apply clinical knowledge to procedural standards to determine the priority action. So you have to, this is something that can't be delegated, clinical knowledge. And the big one is 218, in my opinion. So it's getting down to more like nursing, clinical judgment, recognizing that the timing of administration of anti-diabetic and antimicrobial medication is more important than administration of some other medication. So believe it or not, guys, that insulin and that antibiotics is more important than some other medications. So I know we think of like antibiotics, like, okay, it can wait, but no, the timing of these. So if this is going to be my priority. All right, guys. So work on your establishing priority. This is the Glasgow Coma Scale. You have to kind of, when they give you a Glasgow Coma Scale, they're going to give you behavior like eye opening response, verbal response, and motor response. These are the categories. This is the behavior. And they'll give you a number. They're going to give you, maybe they'll give you the response is 1, the verbal response is 1, the motor response is 1. Now, what is your intervention? So if they give you for I, if they give you 4, for verbal response, if they give you a 5, and motor response, if they give you a 6, what is your intervention for that client? So I want you guys to use these little boxes here. This is the behavior. This is the response. And tell me your intervention. Behavior, response. When do you intervene? When is this patient in trouble? So use this little worksheet to kind of brainstorm. All right, make sure that you know the behavior and the response. Think about the intervention. So let's look at it here. Glasgow Coma Scale. So the behavior, eye-opening response, it could be spontaneously, to speech, to pain, or no response at all. And then verbal response, oriented to time, person, and place. Is the patient confused? Inappropriate words, incomprehensible sounds, or no response? And then for motor response, obeys commands, move to localize pain, flex to withdraw from playing, abnormal flexion, abnormal extension, and no response. And then this is your total score here. So your total score unresponsive is 3. Comatose, less than 8. Best score is 15. So if I have an unresponsive patient, then what is my intervention? If I have a comatose patient, then what are my expected interventions? If my patient has a 15, what are my interventions? So spend a little time here. Okay, because I don't see you not getting a question on Glasgow Coma Scale, because it's something that we have to use for assessment, because we have to act fast, especially if the patient is a less than 3 and it's a new patient. All right, guys, take a little 10-minute break, please.